So MRD, or minimal residual disease testing as we know it, is very important when we do clinical trials. It can tease out the patients who are going to do really well and separate and acts as a surrogate now of progression-free survival and overall survival for patients. Now, the clinical relevance is a little bit more complicated beyond that. There are a lot of issues to consider. I'll go one by one quickly. What we know about MRD is that if a patient gets to an MRD negative situation, they're going to do really, really well. However, we also know that some of the patients who get into MRD negative situation will relapse. So MRD at this point in myeloma does not equate to a cure. The second thing, if a patient is not in an MRD negative situation, or if they're MRD positive in other words, they are probably going to relapse sooner. But here again, there are probably about 15 to 20% of patients who are MRD positive who enjoy very sustained remissions. Thirdly, we don't know what really, some of the patients who are MRD negative will lose their MRD negativity and turn MRD positive during the course of follow-up. And we know that that's not good, but we don't know whether someone who is MRD positive should undertake very extensive and very aggressive treatment regimens to get converted to MRD negativity, because that may be a function of the biology of their disease that makes them MRD positive versus another person MRD negative. So we have this syndrome where patients, are facetiously, the myeloma doctors say MRD anxiety syndrome, which is a patient typically learns about this and they realize that they are not MRD negative and they really want to have more and more aggressive treatment. So there is a law of diminishing returns here. At some point, you'll end up with more treatment than you need, and you may actually suffer harm at this point because we are giving more treatment than is needed for that particular patient. It may be, for at least some patients, possible to live at a low level of MRD positivity with sustained suppression of disease, and then if the disease actually takes off clinically, then get new treatment. The downside to getting more and more aggressive treatment for a minimal level of disease is that you end up using all the drugs in a very short period of time, and then you're on experimental agents when the disease eventually does relapse for that patient. So it is important to understand that MRD is very relevant for myeloma in general, for the science, and MRD positivity is a bad thing generally, but we actually don't know how to deal with MRD positivity for every patient. We know that patients with high-risk disease, patients who have a lot to lose from their myeloma because the disease by itself is very aggressive, patients who are young, they probably should spend more effort trying to get to an MRD negative situation. For patients whose disease is relatively slow growing, and we call them an MGUS-like phenotype of the disease, where it means that the disease is moving but not moving so fast, for those patients to get extra aggressive treatment to get to MRD negativity may not be good in the long run for them. So I would say that think about MRD, measure MRD, but be cautious in its clinical interpretation outside of a clinical trial.